Everyone, please settle down. We're going to start the session soon. Hello, everybody. Please settle down. We're just going to be starting the session.
People are not coming. I don't know. Kevin, can you ask people to come inside? So many of these people are not there. Right, and we should start.
Good evening, everyone, and a very warm welcome to ABPMJY Best Practices in States Learning and Leading session. As we celebrate the 5th anniversary of ABPMJY, the states and union territories have played a very crucial role in the success of the scheme through their best practices in implementing the scheme suitable to their cultural and local contexts. Today's session on states' best practices and innovations is one such opportunity for the states and union territories to showcase their successful initiatives, and this to serve as a cross-learning platform for states. Without much ado, it is my pleasure to welcome the distinguished panel for today, led by our chairperson, Mr. Gagandeep Bedi, a seasoned officer from the Indian Administrative Services, batch of 1993, Tamil Nadu cadre. He has a distinguished career of over 30 years and currently holds the position of Principal Secretary, Health and Family Welfare, Government of Tamil Nadu. I would like to welcome our first panelist on stage, Dr. Rathan, Kelkar, an officer of the Indian Administrative Services, batch of 2003, Kerala cadre. In his 20-year career, he has served across a wide portfolio of the administrative services and currently holds the charge of Secretary Electronics and Information Technologies, Government of Kerala, and also additional charge as Executive Director, SHA Kerala. Our next panelist for today is Dr. Siddharth Singh, an IS officer from the batch of 2005, Assam Meghalaya cadre. He has had an exemplary career in the services and currently holds the charge of Commissioner and Secretary, Medical Education and Research Department, as well as CEO of Atal Amrit Abhiyan Society, which is responsible for the ABPMJ scheme and the State Assurance Scheme in Assam. I would also welcome to the dais Ms. Remya Mohan, an IS officer from the batch of 2007, Gujarat cadre. Through her illustrious career in public services, she has served across many portfolios and currently holds the position of Mission Director NHM and Additional CEO SHA Gujarat. Our next panelist for the session is Dr. R. Rajesh Kumar, an officer of the Indian Administrative Services, batch of 2007, Uttarakhand cadre. He currently serves as Secretary of the Department of Medical Health and Medical Education, Government of Uttarakhand. I would like to finally extend a warm welcome to our moderator for the session, Mr. Rohit, an officer of the Indian Revenue Services, 2013. He has been an integral part of the policy making and implementation of the ABPMJY scheme and currently holds a designation of Joint Director at NHA, leading IEC and SPC divisions. I would like to now invite Mr. Rohit to open today's session.
Thank you, Neonka. So once again, I extend warm welcome to all the dignitaries on the dais. And this has been one of the, Arogya Manthan has been one of the very, integral part of NHA. This session, best practices session of the states has been very integral part of the Arogya Manthan. And we dedicate this session to the efforts which have been made by the states to actually take the scheme, implementation of the scheme to a next notch. We have, as at the time of inaugural session, it was presented that this year we have received around 70 best practices from 24 states, and we have been really quality conscious this time, and that is how we have filtered on the numbers of best practices we have received. Otherwise, we would have received many more nominations in this regard. I would say that. Being part of this team which has been implementing Ayushman Bharat from the 2019, I have seen the not only the states, not only the scheme expanding to its full horizon, but also the states taking the scheme, different states. There are like, if I talk about in 2019, there were states which were south of Vindhyas. They were kind of leading the implementation of this scheme. There were hardly, and it was kind of taken for, like 50, 60%, 70% of the utilization of this scheme was from those 5 or 6 states. But let me tell you that as we are growing up, as we are taking these schemes to the, like we are in the 5th year of this scheme, this has now, there is more equity in the PMJY, more equity in the implementation of the PMJY. And even the states in the northern part of the Vindhyas, like if I call it UP, Madhya Pradesh, almost all the states are doing better. There are innovations. More importantly, as we were showing repeatedly, I think by now you would be remembering that one figure is coming again and again. That is 26 states and UTs have converged their state schemes with Ayushman Bharat. But that doesn't mean that these are the states only who have expanded the base. There are another 4 states who have the expanded base and they are implementing, though they have not converged the scheme with us. We are looking forward to them that they would in future converge the scheme with us, and because states like Kerala, Tamil Nadu, Andhra Pradesh, Maharashtra, Gujarat. This year Maharashtra, a few months back, have declared that they are implementing universal health coverage, and they will be implementing completely in convergence with Ayushman Bharat PMJY. So we have 12 states who are implementing this scheme in complete convergence, USC in convergence with PMJY. Now, if I talk about the trends, this is the best practice session. So it's important that some trends are being told to you. That the trends are like, there are states, if I see the NSSO data, for 75th NSSO data, the bottom 2 quintile of the NSSO data is the hospitalization rate is 2.15%. But you will be happy to know that we have already crossed 2.6% hospitalization rate in 2022-23, and in the year 23-24, the trend we are going will be crossing 3%, more than 3. It would be probably 3.1, 3.2% hospitalization rate, which is much better than the national average of 2.9% in terms of hospitalization rate. So this talks about the success this scheme is kind of bringing in equity to the access to the healthcare. If I talk about the episode cost is the cost of the treatment, pre-authorization cost. So the one figure was shown by additional CEO NHA in the previous session, wherein he has shown that the total cost, if these services were availed in the public-private setup, would have, out of PMJY, it would have been 108 lakh crore rupees, 108 lakh crore rupees, right? And in PMJY, we have spent around 70,000 crore rupees. The genesis of this figure is again traced to the NSSO data, which says that the per cost of hospitalization in public sector is around 3,200 rupees, and in the private it is around 31,000 rupees. And you will be surprised to know the episode cost in PMJY is 13,298 rupees. So that way we bring efficiency as well. And that doesn't mean that we are just giving dialysis, because 60% of the total outgo under this scheme goes to the tertiary care. Now, this is about how PMJY is bringing efficiency in the ecosystem. Now, another trend which I like to highlight with you, there are 2 kinds of states in the ecosystem. One, which is kind of Kerala, Tamil Nadu, which is where the utilization rate, Kerala is around 7% this year. Hospitalization rate is 7%. There is another state, Gujarat, Andhra Pradesh, where the per episode cost is hovering around 26,000 rupees. Per episode cost, okay? But the utilization rate in Gujarat is much lower than the Kerala hospitalization rate. Andhra Pradesh, it is also around 4%. In Tamil Nadu, there is a balanced state where in terms of numbers I'm talking, it's not about any qualitative thing, but it's more about the numbers. In Tamil Nadu, the hospitalization rate somewhere hovers around 3%. And the per episode cost is also around 12,000 rupees. So this brings the diversity in the implementation this scheme the states are bringing, and every state is a unique case study in itself. If you get into numbers, these numbers are so interesting, and when you will listen to the best practices, you will get to know how these numbers, you will be able to explain these numbers, you will be able to find meaning into these numbers, that how it is happening. Interesting fact, Gujarat, Andhra Pradesh, Haryana has one of the highest public sector utilization, something around 12 to 20%. Between 12 to 20% is only public sector utilization. However, in case of Kerala, it is around 60%. In case of Tamil Nadu, it is around 50%. Please do not attribute any qualitative aspect to all of this. I'm just telling you the quantitative things, right? And we are not really, of course, it is a mandate under PMJY that the public sector should strengthen, right? But at the same time, we are very much in favor of the fact that person should have a choice to avail the services. A patient should decide, and public hospitals should compete with the private sector, as we have started doing in case of PSUs post 1991. In case of we brought liberalization, we don't want any. This reservation policy is all right. This is not aimed at, it has a different philosophy altogether. There are many interesting things. If I would request all of you to please turn the leaves of the best practices booklet, and you will figure out that there are many good innovations. Gujarat has this year brought a TKR application. Gujarat was at one point of time catering to 70% TKR cases in the country. Total knee replacement cases. So they thought that, okay, this is a concern. It's fine that Gujarat is becoming, it is attracting people, it has technology and facilities. But again, that was a point wherein the state thought that it should act upon that. In the same series, we have one good innovation by Jammu and Kashmir. That is this year you would have, all of you are aware that this year the governing board of NHA has decided to structure the district implementation unit across the India. And we have come up with a guideline in this regard. So Jammu and Kashmir, with the help of GIZ, has developed a district implementation unit application. That application primarily is aimed at, controlling or facilitating the operation of district implementation unit. That is about that, whenever the DIU is going to fields for inspection, they can feed in the data, they can mark their attendance. You have graphics to monitor their operation. We will have a short video about that. But before that, I would request the CEO SHA Jammu and Kashmir, Mr. Gadkar, to come on the dais, and he would like to say a couple of words about that application, and thereafter I would request the chair to launch that application. We also have standees outside our halls wherein this app is live. You can use that. You can see that how this app is helpful, and I would request the states to please explore if they can use this app as well. Please.
A very good evening to one and all here. It is a pleasure to be here today amongst all of you, and I would like to take this opportunity to congratulate all the dignitaries present here upon the successful completion of 5 years of Ayushman Bharat Jana Arogya Yojana scheme and 2 years of ABDM. As part of best practices, the J&K government has got the DIU Sati application, which is one of the empirical solutions that we have developed to strengthen the district implementation unit in the state for the scheme. Our SHA team has been working closely with the GIZ technical team to understand and mitigate the challenges at the district level through the innovative of district DIU strengthening. And this module application is just one aspect of making the district level operation seamless, and to also support our DIUs in their routine task. This is a win-win solution for both SHA as well as DIU. This application also captures relevant information related to hospitals, IEC, capacity building, training, fraud audits, ABA ID creation, grievances, etc. through separate modules which can be monitored on day-to-day basis. This makes it a one-stop solution for both DIU and the SHA. The key feature is that with a drop-down and selection-based entries, the DIU find it easy to use and that it has a functionality at real-time basis, update on the dynamic dashboard. More information about the DIU Sati application is also available in the fact sheet and the kiosk displayed outside. I would urge the other states to also explore the feasibility of using this tool as it is particularly beneficial in keeping an oversight on scheme implementation and taking necessary steps for implementation of the scheme. I would now like to invite on the stage the officials who are involved with the preparation of this app, the in charge of GIZ, Shri Amit Paliwalji, Muzaffar from SHA, Kirti and Nandini from GIZ who had supported this app. They have been working very hard to develop this app, which has been used by the state for last 3 months, and we have been getting good result. So I really congratulate the whole team for doing this. And that is what I wanted to just say on that thing. Thank you so much.
Thank you, Sanjeev ji. And thank you GIZ team for supporting the SHA team. GIZ has been a very crucial partner to us and has been supporting. In fact, this event has also been supported by GIZ. Now I'd request the chair of the session, Gagandeep sir, to kindly launch this DIU app by pressing the
Presenting the revolutionary DIU survey assessment tools and hub interface Sati mobile application. Struggling with effectively managing their diverse responsibility, DIUs needed something to ensure streamlining of their work schedules and reports. This app would serve as one-stop solution and create a win-win situation for both the DIUs and the SHA. This app has been developed as a pilot activity in Jammu and Kashmir to record the daily and monthly activities undertaken by each member of the team and boasts of a plethora of modules on hospital visits, grievance, claims, fraud control, attendance, etc. It is a distinguished interface with prominent features like user-friendliness, scalable platform, customizable workflow, advanced analytics allowing data-driven decision-making, strong security measures to protect data and maintain privacy, cloud-based infrastructure allowing real-time modifications, compatibility with both Android and iOS devices, state-of-the-art features like geotagging of pictures and reports, auto-population of monthly reports and automated time office functions. Like all solutions to deep-seated problems, this mobile application brings fundamental resolutions like strengthening district implementation units (DIU), improving supportive supervision by the State Health Agency (SHA), improving scheme implementation. The DIU Sati mobile application aids in improved scheme implementation through strengthening of district implementation units by creating a structured work environment for DIUs and improving supportive supervision by State Health Agency. This effective tool will continue to strengthen the implementation of PMJ in Jammu and Kashmir and soar to newer heights.
Thank you, Jammu Kashmir team and GIZ for this application. Now, So, for today's session, we would like to, with your permission, sir, we would like to proceed with today's session, sir. We have 5 states: Tamil Nadu, Kerala, Assam, Gujarat, and Uttarakhand. The format is each of these states will present the best practices in the PPT format, what they have brought. There will be a couple of questions which we will be asking from the stage, from each of the speakers. And thereafter, we will take few questions from the station, very few questions, because we are already delayed by almost 1 hour, more than 1 hour. And thereafter, at the end, the chair of the session will summarize the discussion, and we will present the memento at last. And after this session, we will have another session, which is more of a recognition and felicitation session. So we request all of you to stay back. We know it's a long day, but you will really enjoy that. Okay. Thank you everyone. Once again, I now request Gagandeep sir to present his presentation on from Tamil Nadu about the implementation of PMJ best practices in Tamil Nadu. So, sir, it's fine, sir. You can present, sir.
Yeah, yes. I think that's it. Thank you very much, and thanks for this opportunity, Rohit. I will like to just highlight in about 12 to 14 slides about a few best practices. Mention was made of some of the practices in my initial session also. How in Tamil Nadu strengthens the public hospitals using the insurance funds, and how the claims are used for incentives to the medical teams and for institutional development. And how, this is another best practice, how we are using the corpus fund that we get out of the claims for high-end procedures. So these are the broad themes. Next. So of course the problem statement is that we need to provide incentive funds to ensure that the institutions take interest in this scheme. We also need to facilitate the poor people for the high-end procedures, and we have to reduce the out-of-pocket expenditure of the common public. Next. Now, friends, directly coming to the point, this is the first thing that Tamil Nadu has been envisaging to undertake. Of course, to incentivize the public hospitals as well as to set up a corpus fund. Now, Tamil Nadu actually, whatever the money that comes to the governmental or private hospitals, as all of you will understand and know, as is done in other hospitals, for a particular operation, the same money goes to the private as well as the medical college concerned. Now, we have passed the latest governmental order wherein we give 40% of the money to the hospital itself, the department concerned, to buy the consumables. 17% money goes to the institution for its infrastructure. That is what I had mentioned in the previous meeting. We have a governmental order. 17% of the income is used for that development of that particular hospital. In the case of the government hospitals, it is the CMO who decides. In case of the department, it's the department head in a medical college, the department head who decides. But sometimes the colleague departments also do seek the help of a richer departmental head to fund the infrastructure, and their departmental heads also. Cross-subsidization does happen. Incentive to the operating team is 15%. In Tamil Nadu at present, we have 2 systems. This is for information of doctors. In medical colleges, what we do is 5% of the income that is accrued goes to the medical doctors who have performed. The departmental doctors. 2% money goes to the incentive, goes to the anesthetist. Then 4% goes to the theatre staff. And another 4% to the supporting staff from pathology or other departments, etc., who help. And actually, with the scheme flourishing well in Tamil Nadu, my informal discussions with the doctors do indicate that, say, an orthopedician might be earning anywhere between say 30 to 40,000 a month, and a surgeon might be earning more than a lakh per month extra over and above his salary, because they do get a good salary, and ophthalmologists may get about 10-15,000. It all depends upon the hospital and the place where the college where it is. So this system has ensured that our colleges, governmental doctors also are interested. Of course, corpus fund, I'll come to this later on, and IEC 1% goes to the head office, which is used for dissemination of knowledge. Next. Yeah, next. So that, okay, I'll use this thing. Okay. Then about this, I have broadly spoken about this committee, etc. I think the broad issues I have spoken, how the committee is delegated locally to use the funds. I'll go to the next. Yeah. In 2011, earlier, now let me talk about the concept of the corpus fund, because that is something that I am told is not there in many other states. How the corpus fund is generated and how it is being used for. So initially for the high-end procedures, etc., we didn't have any formal corpus fund. Of course, last 5 years, the Tamil Nadu's comprehensive health insurance scheme is married to the PMJAY. Before that, we had our own state departmental scheme. We are one of those 26 states. We initially had given an amount of 10 crore initially, and then later on in 2011-12, we had given another 25 crore later on. But we found that every year we need to earmark funds. So as I told in the graph before, 27% of the income goes to the corpus fund, and it goes for the all high-end procedures. And 27 from the governmental side. From the private college hospitals also, 3% of their money, we take it for the corpus fund. Because actually private hospitals actually are treating more number of patients in the high-end procedures also. Next, I'll go to the next. Yeah, so these are the 8 high-end procedures where Tamil Nadu allows the renal. Second is actually liver transplantation. First is renal, second is liver. So liver may cost anything more than 20 lakhs, etc. Cochlear implant surgery, then double lung transplantation, heart transplantation, heart-lung transplantation, bone marrow transplantation, and auditory brain implant surgery. So these are the surgeries for which we allow the funds. Other than this also, these are being allowed at the project. There is an IAS officer, Mr. Govind, who is sitting in the front. He is dealing with this fund. He gives the approval after the concerned hospital's recommendation for the high-end surgeries. And we have had hundreds of surgeries conducted through this. And there are some other special cases also which come to the state level headed by me, and which we sanction also from out of the corpus funds. And they are especially for the cancer patients or very high-end heart surgeries, etc. So these are the steps which we have taken. I have already told how we are using the corpus fund for the high-end surgeries. Let me come to the statistics. Yes. So using the corpus funds, this so far I have told you how we are using the corpus funds for high-end surgeries. Now, before coming to this slide, let me just tell you that since the last about 4 years, we have already since the last 10 years, so we were using corpus funds earlier, we have already done high-end surgeries, cochlear implant more than 5,000 surgeries, liver transplantation 1,525 surgeries, bone marrow about 2,000 surgeries and all. So it's a very successful method. Now, this is the point, that steps which we have taken to ensure that how our government, this is the second issue which I am highlighting, how our government medical colleges and hospitals are actually very popular for the public, because 50% of the amount right now of the PMJAY goes to the governmental hospitals, because we are actually investing a lot in the last 4 years itself. We have actually invested. This is besides the existing infrastructure. We have put up 25 cath labs. We have got for the heart, we have got hub and spoke STEMI centers. We have put 64 CCUs, ICUs, CT scans, MRI scan, dialysis scans, accelerators, etc. So the government of Tamil Nadu is actually focusing to bring the governmental hospitals and medical colleges on par with the private colleges and ensure private hospitals and ensure that the infrastructure is on par. A lot of recommendations I get as health secretary recommending surgeries to be done not in private hospital but in government hospital, because you will agree with me that the governmental system, the doctors will have the maximum exposure to the patient. So if the infrastructure is similar, perhaps people will like to go to the governmental system itself. Okay, so yeah, we have, this is basically again the continuation of the previous slide, where I have indicated that a lot of funds are being spent by Government of Tamil Nadu to improve its infrastructure for the governmental healthcare system. Of course, the money that comes from insurance doesn't go into these high-end, because that money is limited. That will not go into hundreds of crores, etc. But we are giving a lot of focus on the high-end equipment in order to ensure that our governmental hospitals are on par. And that's why in the last I have told that because of this itself, this year we have governmental and private hospitals have got 50% share with each other. This is also the same. This is the graph that indicates over here. The red one is the private hospitals, the blue one is the governmental expenditure. So earlier the insurance money was going across the years more towards the private healthcare system, but slowly we are catching up, and this year at present the money that is spent on the governmental healthcare system is almost equivalent to what is being done in the private healthcare system. Of course, there is a corollary that for the high-end procedures, still the private healthcare system do get more money in this regard. Okay, so this is the broad, this is just two more slides, and then I'll mention one more issue and then I'll close. So since 2009, when the Tamil Nadu government started, we were one of the initial states who started the healthcare system. 1,31 lakh beneficiaries have benefited with 219 crores from the healthcare system. So perhaps that is why Tamil Nadu is proud to give a good healthcare system, both governmental and private system. And the third bullet point, if you see, more than around 14,000 beneficiaries have had high-end procedures for which the committees have approved 1,155 crores high-end procedures. So the point we are trying to highlight that in Tamil Nadu, the broadly focus of the government is that if you are a patient with a major disease which requires a major intervention, you need not worry. The PMJY and the state health insurance scheme together will ensure that high-end procedure patients will also be taken care of. So before I end, I will just like to mention one more best practice for which actually Tamil Nadu has been asked to perhaps present. We are shortlisted in the Chief Secretary's conference before the Cabinet Secretary. That scheme is called NK48. In Tamil there is a word in Uir Kapom 48. That is, henceforth the life will be saved within 48 hours. For this scheme, Tamil Nadu government has started in the last around 2 years, 1.5 years, wherein the government has put this is an assurance mode scheme. 100 crore we give every year, in which we have empaneled 692 hospitals across all the highways in the state. So they are both governmental and private hospitals. Any road traffic accident, if it is there, that accident victim can be brought by anybody to the hospital. First 2 days of the treatment, first 48 hours of the treatment, whether that person is having a card or not, the card is immaterial. First 48, the person is treated free of cost, for which the government is pays, and it's on assurance mode. We give the money to the hospital, both government as well as private hospitals. Nearly 1,75,000 patients, road traffic accident patients, have been treated under this scheme in the last 48 hours. And the data of, compared to 2021-20 on an average data, statistics do indicate that the number of fatalities because of this NK48 scheme, it has reduced by about 7.1%. So this is the broad, this is also a corollary of the universal health care, and so we are being asked to present this in the Chief Secretary's conference also. Thank you so much.
Thank you very much, sir. The scheme in Tamil Nadu, if I remember, was launched in 2014. From the presentation, first of all, this time I just wanted to highlight that what actually we want to, what you must have figured it out, but I again want to reiterate that what was that we wanted to present before you, that what other states can emulate. The first thing is that NHI has issued a guideline for fund utilization in the public hospital. Now you have an example of Tamil Nadu who is effectively using this money, and not for last 1 year, but for many years, creating a virtuous cycle wherein the money earned from this scheme is fed into the developing or augmenting the public health infrastructure in the public hospital, again, which is enabling them to compete with the private sector and attracting more beneficiaries. So we would request all the states who have not yet devised any policy in this regard to please enable that, and also follow up upon your, like public hospitals to see that, they are using. Tamil Nadu, one interesting fact, if you would have seen in the Tamil Nadu graph, it was that it has, now it is, there is a graph which is coming down constantly, and there was one graph which is going down, now at par, exactly at 50%. So that is the point. That is probably the most ideal situation which we would like to have in under PMJY, and that from all of the states. Right. Okay, so there is another 2-minute video which state would like to present. Yes, we can present that video quickly. Video present kariye. We'll come back.
Government of Tamil Nadu launched Chief Minister Kalinga's insurance scheme for life-saving treatments on 23/7/2009, the flagship scheme of the Government of India. Pradhan Mantri Jan Arogya Yojana was implemented in integration with Chief Minister's comprehensive health insurance scheme in the state. One of the many salient features of this integrated scheme is that the empaneled public hospitals are strengthened from the insurance claims earned by them.
I am Dr. Rajan, Dean Madras Medical College and the Rajiv Gandhi Government General Hospital. Because of these funds, flawless management is happening in our institution. Those who are treating the patient, staff nurses, doctors, paramedical workers, they get incentive remuneration, and 40% of the fund is utilized for procurement of the drugs, equipment, and other infrastructure. Whatever the things which they wanted to develop for the department, they can decide.
27% of the claims amount approved is added to the corpus fund, due to which beneficiaries who require high-end procedures can avail life-saving treatments that cost over and above the sum insured of rupees 5 lakhs, giving them a fresh new lease of life.
High-end procedures are happening in our institution. Recently, liver transplant has been successfully done under CMHS scheme along with the PM2 integrated scheme. And 6 patients are alive and they are hale and healthy. These are all possible in government institution because of this insurance scheme. Patients are directly benefited because of this bone marrow transplant. See, even a rural person from remote areas, they come to our GH and they get treated. These are all possible because of this wonderful scheme.
வணக்கம், என் பேர் பிரியங்கா, வயது 24. நான் ஆயுஷ்மான் பாரத் பிரதான் மந்திரி மக்கள் ஆரோக்கிய திட்டத்தின் ஒருங்கிணைந்த முதலமைச்சரின் விரிவான மருத்துவ காப்பீடு திட்டத்தின் கீழ் நுரையீரல் மாற்று அறுவை சிகிச்சையை எவ்வித கட்டணமின்றி மேற்கொண்டேன். தற்போது எவ்வித சுவாச பிரச்சனையின்றி நலமாக இருக்கிறேன். இத்திட்டத்தின் வெற்றிக்கு நானே ஒரு சிறந்த சான்று. இதற்காக பிரதமர் அவர்களுக்கும் முதலமைச்சர் அவர்களும் என் மனமான நன்றியை தெரிவித்துக் கொள்கிறேன். நன்றி.
Interesting that as I was discussing in the beginning of the session that, like Tamil Nadu has, again I use the word in a quantitative terms, that it has been able to strike a balance in terms of hospitalization and also in terms of, rate of hospitalization as well as the episode cost, that is the amount per cost treatment. it is sandwiched. I mean, like your neighbors, Kerala and Andhra Pradesh, they are showing two different trends. Kerala has a very high hospitalization rate. Of course, there is historical, and many other regions, there is a health-seeking behavior of the population. And there is Andhra Pradesh, where the episode cost is more than 20,000 rupees. Your episode cost is something around 12,000 rupees, 10,000 to 12,000 rupees per rate of, hospitalization. I actually wanted to, and this is for all of us, whenever we talk about universal health coverage, these are the two parameters which is most debated upon to test whether it is going to be a sustainable thing or not. Sir, how the state has been able to, is there some, it is organic, or there has been some effort in this direction to control both these parameters, sir?
Both. Two things come in my mind in this regard. One, of course, Tamil Nadu is bigger state. Of course, Kerala has a lot of healthcare is very good. Tamil Nadu is a bigger state with a very expanded healthcare system. The two things so one is that not only our tertiary care system, even our secondary and primary healthcare network is very strong. I will especially like primary health care. If we see the state has about 1,800 primary health centers, and then we have got 8,000 plus health sub-centers, etc. on the primary health, 497 urban primary health care centers in the primary sector. Our strong point is we have a very good secondary healthcare system also, with the state having nearly 300 very robust healthcare system, which state keeps on investing over there. We have had discussion. The one is that the patients keep on coming to the hospital network then and there. Perhaps we may not compare ourselves to our neighbor, but as compared to many other states here, the patients have a in their very close proximity healthcare system. So overall health expenditure, broadly speaking, the studies indicate, I'll not be able, is comparatively lesser over here, because then and there healthcare system is available at the doorsteps of the people. We have also got Tamil Nadu, like perhaps his other southern neighboring states, has also got a few schemes wherein we try to detect the cost of try to detect the diseases, especially the NCDs amongst the patients at an earlier stage. For example, all over India, there was an article a few months back about a scheme called Makkal Tadi Marutvam, that is the doctor or the healthcare system seeking the people, in which we have paramedical staff going house to house and detecting NCDs across all the houses, and we have actually covered in the last 2 years 1 crore population. We have detected lakhs of people having diabetes and hypertension or both. And also including these visits, we are also detecting cervical cancer, oral cancer, breast cancer patients also at an earlier stage. So I think the broad good practices does ensure in the end that people do not come at the terminal stage mostly, because of which the cost of the healthcare network is high, and we try to detect early and treat early. Of course, at the same time, we have for fixing the cost of the procedures, there are 2-3 tiers across the system, wherein actually the private and governmental systems both are taken into consultation before we fix the cost of each and every procedure. So because of this, we try to ensure that the cost is not too high, because then we will not be able to reach as many patients with the existing financial budget that we are having. So this is my answer to your question.
Thank you very much, sir. Very important point has been highlighted, that if we keep the secondary tertiary care system differentiated from the primary and the preventive care, then at some point of time this is going to become unsustainable. So we have to see that this is integrated, and there comes to a point very important, that is continuum of care. And though we have seen many good practices, but my wish is, being in NHA, our wish is that to see one state which does implement continuum of care in true sense, wherein the primary healthcare system is duly integrated with the secondary and tertiary healthcare system under this scheme, and there is a backward and forward linkages to establish referral as well as to follow up treatment. And that we would like to see, if maybe next year in the Arogya Manthan we have one case study wherein one of the states is actually doing this in a full-fledged way. I know there have been some attempts in this direction. I know Kerala is doing something. I know Uttar Pradesh, there was some attempt made in this direction. Few other states, but one which is in terms of a model which can be replicated, we would definitely like to see. Now, thank you, sir, and once again, and now we will go to Kerala. I'm inviting Rathan, sir. Rathan, sir, has been associated with this scheme from the beginning of our scheme, and sir, we would like to, Kerala has been, today also Kerala won an award for highest per lakh beneficiary utilization. I request you, sir, for your presentation. Thank you, sir.
Thank you, Rohit. Good evening, everyone. How are you all doing today? You seem very depressed. You know, what's the most difficult task for a speaker at this particular point of time is to come on stage and 300 eyes staring back, saying, "Ab kya batane wala hai? Bolo jaldi se." And this is the kind of feeling I get when I am sitting there on the stage. As we are all here to learn something from each other. So let us all make it a happy event. A bit of smiles on your faces would do a lot of good for us sitting on the stage. So to begin with, let me tell you what I have in my presentation. We did a bit of work on our IEC. We would not like to call it an IEC. IEC is more of a terminology where you are bombarding people with a lot of information on something that you want to convey. We would want to believe it is a change in the behavior that we are attempting to bring about, what we call the behavioral change and communication, for which a line item exists in the NHMPIP. The SHA who are here, who are not aware of it, please make use of it for your SHA purposes as well. So this is what we should all attempt to do. Is the slide moving on its own? Yeah. I don't know who's got the control of this. I'll finish it very fast. You need not move the slide. So this is what we are trying to do in IEC. We are looking at changing the behavior of people towards accepting what we're trying to tell. Now, on every No Tobacco Day, we always bombard our media with the no tobacco signals. And what are we trying to do? Are we really meeting the aspirations of people and trying to change the way in which they are looking at your advertisement? I mean, that is what we wanted to do. So that is where we identified, we still had a problem, though it was highly, or rather Kerala is a highly literate state, and we would like to believe that everybody knows everything, but we did a dipstick study of where we stand in terms of our activities, and then we understood that there are still some areas we have not reached in terms of communicating our intent in this scheme. So we got all the relevant stakeholders, we had the relevant departments, we had the NGOs also participate, and we had a workshop through which we organized a brainstorming session to understand where we stand in terms of information dissemination. And these were the outcomes of the workshop. The outcomes were that there is still a section of visually impaired people who are not aware of the scheme because probably it's not available in the form of Braille. There is a section of migrant laborers who are not aware of the scheme because there are different approaches to reach to them because they are in camps and they are in different other areas of work and different language barriers. So we had to overcome that. We had to still reach out to the tribal population using our tribal volunteers. So we had all these relevant departments come together, and we have a very strong area of Kutumba Shri and Anganwadi workers who are our foot soldiers in the social justice department. So we got all of them together to pass on the message of Ayushman Bharat scheme and how this can bring about a change in the lives of people. And that is what we did, following which in the last 1 year we could reach out to everyone in our own innovative way of having Braille for differently abled, conduct events for tribal communities and ASHA trainings and so on and so forth. So this is what we did in the last 1 year in terms of our dissemination of our intent. And of course, the challenges is not in so far as the technology is concerned, it's more so in terms of integration of minds between different people having seats in different departments. I think we all work in silos. We have multiple budgets for all of us to pass on the same information in all the departments, but somehow we do not work together as a team, which is the biggest problem, and we are trying to overcome that as well. So that was the first innovative thing that we did in the last 1 year. Now coming to the public fund utilization, as has also been told by Tamil Nadu, we are not so different. So the problem statement we have identified for ourselves is we want to use the private sector participation only for strategic purchasing, and we would like to meet most of our expenses of meeting the healthcare using our public health facilities, which is also funded by the state separately through the plan fund, the NHM funds, the ABEAM funds, and multiple other channels. So this is how we are faring right now in terms of number of claims in the scheme is around 60%. Similarly, the amount is also around 60% of the scheme still comes to the public hospital. Now, we have a detailed guidelines issued on how people should be using these funds, which are given to them as package rates. And the trend we are seeing here is a majority of that amount is going for procurement of medicines, consumables, and also HR, and to an extent also in building infrastructure. About 20% of that is being spent. So the guidelines is very broad. The specifics are gotten into by the hospital development committees, which are having the say, because every hospital has its own customized problem, so they have to have that flexibility. That is what we provide. And these are some of the things that they have done in the hospital setup. Now, the one thing which we all need to believe in is the public hospitals should come up to the expectation of building trust amidst the people, and the trust would come about if you have an assured quality of service, and that is what we are attempting to do in very close liaison with the NHM, the Department of Health and Family Welfare and Medical Education. We work very closely with them, and we have a very good bond with the private sector, and they chip in a lot in terms of our partnership with the private hospitals in PMJ, as well as in other state level schemes. So these are some of the steps that we have already undertaken. We have our own policies. We have reservation of treatment of some of the packages exclusively for public hospitals, because we feel they have evolved to a stage where they can handle many of these packages for themselves, like oncology, and that is already completely with the government. And another thing is we have to sensitize our hospital development committees, which has people from the political executive, from the hospitals, from the district administration. So these are the committees which operate a particular health facility. So the amount which is going to them is what is being attempted to be utilized in a very efficient way in terms of building infrastructure, which caters back to the community. So that is one of the challenges we are facing, because there are multiple sensitization sessions needed for all of them to understand what are the priorities for that particular facility. And ultimately the outcomes is there to see in the NFHS 5 and 4. If you're looking at out-of-pocket expenditure, we have reduced by quite a significant amount. That I think we were around 6,900 in the NFHS 4. We've reduced to 6,700. So I think that is quite a big jump. We have improved our infrastructure facilities, so we could build the trust of people, and an assured quality of service is always there for the public when they visit the public health facilities. And of course, the improvements in the facilities also adds up to the quality of service. So we have been able to give improved services. We've been able to increase our certifications in NQA as well. And of course, ultimately this all leads to improved delivery of services for our citizens. So this is all I had. I'll be happy to take any questions. Otherwise, I would also request you to be very, very nice to us for the next 30-40 minutes as long as we finish the session, because this is an experience sharing session where we learn something from other states learn something from us, and if we have smiling faces in the crowd, it adds a lot of value to all of us. Thank you.
Thank you very much, Rathan sir. You have been kind of from the discussions, one thing has really come out very well. In my college days, I used to read a concept called Maslow's hierarchy of needs, if you remember, right? And if you remember that, there was a movement from quantitative things to qualitative things. If you move from, first it was basic needs like khana chahiye, rahna chahiye and all that, right? PMJY, after 5 years of implementation, has come to a stage where we need to move from quantitative things to qualitative things. When we are already crossing the NSSO barrier, NSSO national threshold of 2.9%, it is very much required that now all of us, all the states need to think towards the qualitative aspects. And that is how it comes. The IEC, that disabled people should have a Braille Lipi based IEC, is a qualitative improvement in the system, right? So, and more importantly, the growth, the improvement in the implementation doesn't cease merely after you achieve a good number. So if Kerala has 5.7 or 7% utilization, that is not the end of the story. Probably that is beginning of a new story, right? Another very important thing, we have one set of states, like we have Karnataka, where there is a gatekeeping mechanism for utilization of this scheme. We have Uttarakhand, which also has a limited gatekeeping. But in Kerala, where the health seeking behavior is highest, also the people are very informed and they are very, very particular about their rights and entitlement. People are choosing to visit the public hospital. They are choosing to visit the public hospital with a utilization of around 60%, both in terms of number as well as in terms of amount. So that tells a story. And for all of us to really understand and probably follow in our respective states. I will ask Rathan sir a question. We'll take questions from the audience at the end. I would not like to miss this opportunity to really, seek some more information from our panelists about the initiatives they are bringing. Sir, I understand, like there is a reason for why historically Kerala has very high utilization rate. But what is the factors which you attribute to a very low episode cost? Like that is how you are still sustainable, in the sense that if it goes like Gujarat, then probably things will really become very difficult. So.
Okay, I think Rohit has understood Kerala so well that you have already answered during your speech the question you asked me. You already answered it actually. But let me just speak from the side of the data. In the last 4 years, if you look at the data, 63% of our claims have come mainly from the general medicine packages. General medicine packages, if I look at subdividing that further, I think the significant of that is in the dialysis, which also has a very low cost per episode. General medicine, the ward packages would be say 3 to 5 days, would still be low. So those adds on. Then subsequently, if you look at the other packages which are in bigger use in Kerala, that would be say ophthalmology and medical oncology. So these are all having packages which are a little less costing. So to that extent, I think what you said in terms of utilization per episode, if you look at the overall picture of the number of claims generated from Kerala, highly, the reason mainly being people are having a high health-seeking behavior. People also understand, because of our multiple activities of reaching out to them, they know that there are opportunities for multiple packages which PMJ offers. So all of this has contributed to a a figure of a low episode cost. That is mainly because of our high inclination towards the medical packages.
Thank you, sir. So one of the reason you said that it is because of the utilization of higher utilization of medical packages in the state, which is balancing out the per episode cost. Sir, it's about the quantitative things, but is there something qualitative aspect also that one of the reasons I feel is that it is you have very dominating presence of public hospitals, which is enabling you not to change your package rate for last few years, and you are still managing that. That is one of the factors.
Yeah, absolutely, because the public health facilities are also getting funded, like I mentioned, from other sources like the plant fund, the PMO beam, and then the NHM funds, and even the local body funds. So local bodies in Kerala provide a lot of support to our local health facilities. So the model which is working in Kerala is, I think, for us to understand what works in Kerala, we have to step a minute back and see where Kerala has started from. There is a high focus on social development in Kerala. This has been from many, many years. And there has been a high amount of involvement of public in safekeeping of the health institutions, the investment of time and energy into Anganwadis, women empowerment, social movements, multiple political reforms which has happened over the years. All of this has contributed to a point where there is a balance between the demand from the people and also the supply from the state. So here, when I say demand from the people, we need to understand that these institutions of say health facilities like the PHC, CSC, Taluk Hospital, District Hospital, they are all having a mechanism of interaction with the local self bodies. So the local self bodies give a lot of funds for these facilities. They are also sitting in the hospital development committees. So they are representing the voices of people. They are demanding these things from the state. We have created enough empowerment, our facilities also, to meet the demand. So that is one which is, it's like a golden handshake between the aspirations of the people and the supply from the state, which is very successful. And like you rightly pointed out, that is what has led to a point where people trust public health facilities to an extent that they would prefer public health facilities more than the private health facilities, mainly because of the point that there is a quality of healthcare delivery which happens in the state of Kerala. That is why people believe that they will be taken care of if they go to a public health facility. But to bring that trust amidst people is a very challenging task, and that is what should be the investment of everybody to, over a period of time. It takes a lot of time, and Kerala has reached this over a period of time because of the kind of focus it has been having on the social development.
Thank you, sir. One more thing I just want to, before we move to the next speaker, one thing very interesting about Kerala. Kerala is one state which is really looking on vertical convergence of the schemes. Vertical convergence. Horizontal convergence is when you are converging health insurance schemes, similar health insurance schemes. But vertical convergence is when you are even trying to converge schemes related to health department, which are not purely insurance in nature, but targeting at certain elements. So Kerala has, other than Kerala is one of the state which has integrated Karun Benevolent Fund. That was a horizontal insurance because that was insurance led. But there is another scheme called Arogya Kirnam, which is targeting at children up to 18 years of less than 18 years of age, like RBSK. And there is another scheme called now, which Kerala is very soon going to launch on our platform, that is Shruti Tarangam. That Shruti Tarangam is about
cochlear implantation.
Cochlear implant. So that is very interesting. These are the way through which you can really look for fiscal, the fiscal stress which this is going to create, this scheme. If you converge more and more schemes on a same platform, it will not only bring efficiency, but it will also ensure some kind of fiscal sustainability. That was another point which I wanted to feed to all of you. Now we have another state, Assam, with us. We have Siddharth sir. He is CEO and he's also the Commissioner Medical Education in Assam. Last 1 year has been phenomenal in the journey of Ayushman Bharat implementation in Assam. We have not only seen highest Ayushman card created in the state. Before last year, we have just 6 lakhs Ayushman card in the states, and of this year almost we have reached around not exactly remembering a number, too many numbers, 1.5 crore if I remember correctly. Most importantly, that this state has decided to converge its scheme, that is Atal Amrit Abhiyan, with our scheme, with PMJY, and the utilization of a scheme has completely taken off in a great way. And Assam presents a model that wherein if we work for 1 year for the implementation of the scheme, probably in another year we will see all great outcome. So now I invite Siddharth sir for his presentation on how he has been able to, because I see the success of this whole initiative in Ayushman card creation, and I request sir to make the presentation on the same. Thank you.
Thank you, Rohit. So we all have been talking about north of India, south of India. Now east of India is also featuring. So I'll just briefly talk very few slides, because I don't actually like slides with too much of matter written in it. So this is the problem statement that we had basically, and this is the problem that most of the states have been facing, is when they were utilizing this card creation agencies, probably there was some trust deficit which was there between the public, the government and the agencies. So which was affecting the performance of these agencies. Then there were certain malpractices. It was identified in Assam, I'm sure must have been the case in other states also, wherein, because this card is like a credit card, so it's a credit card being paid by government. So 5 lakh rupees, for 5 lakh rupees, people can always ask for 100 rupees, mujhe 100 rupees de do, main card banwa dunga. So this was something which was happening in a few instances in Assam, and we stamped it down very hard. And finally, the community connect was missing. And that is the case in, I think, a lot of states, including ours. When the card creation agencies were working, they do not have a community connect. So you cannot get to the people by utilizing a commercial organization for that work also. That is what we felt. And this was late. So this is some of the things. We made it into a mass movement. So we have utilized the field level workers, the Ashas, Anganwadi workers, ANMs, Sakhis, multi-purpose workers, and it was a multi-departmental effort that we ran. So we drafted in something like 35,000 field level workers. And mind you, Assam is a mid-sized state. It has only 3.5 crore population. It's not like a UP with a 25 crore population. So, but still we have been able to utilize 35,000 field level workers. Now, this for me serves two purposes. First of all, I have extensive IPC that is going on, which is the best form of IC, I would say. So, it's a model wherein I am assured of making the scheme features available and known to the beneficiaries, and the field level workers themselves come to know. What is our interface with the public largely for primary health? It is the Ashas. Now Ashas, if they don't know about this scheme is never going to take off. At least not on the primary sector. So this is serving my dual purpose. Now a lot of training to these field level workers has been given, and NHA has been very kind to provide a lot of trainings to us, and we have relayed these trainings in a cascaded mode. And this is another thing that we have added. From the NHA side, there was a 5 rupees incentive. Our government felt that let's double it. Let's make it so attractive that it should be done in a mission mode. And this is something which has worked quite well, I would say. Nothing speaks like money in some certain cases. So this is something that has worked very well in case of Assam. So and the actual outgo is not very big. It's not that you end up spending hundreds of crores. It's a very small amount that you end up paying, and you're paying ultimately to your field level workers who otherwise also are very lowly paid. So it's a big incentive for them. And then we have also incentivized the supervisory staff. So the
ASHA worker gets, the ASHA supervisor also gets something. The district program manager, the block program manager also. The entire outgo is not a huge amount. But they are incentivized to work to popularize this scheme. And this is how we have been able to. The IC campaign, we have also worked. We saw from Kerala, which has done great work. We have also used a lot of IC. In fact, one of the things that immediately came to my mind, as Rohit was saying, about differently abled, for example, in Assam, we have just recently adopted a policy that any promotional video, any AV that we'll make, will also have sign language. So all of our AVs, if you will see now, will have sign language also along with it, which I think maybe first for a state, I'm not sure, but definitely that is something that we are looking at. Then apart from these field level workers, our PMAMs and all, we have been sort of creating a healthy competition between them. The field level workers, we have created something called as the Ayushman Yodha. 2 days back on the Ayushman Divas, we have felicitated them and given them a lot of incentives. So one of our Ayushman Yodha, he did something like 20,000 EKYCs. He would be getting 2 lakh rupees. Apart from the incentive and the certificate that we have given him. Now 2 lakh for a field level functionary is a huge amount of money. And once it is known to others, they also keep on, and this is a competition that keeps on happening. So there were certain things we were not able to basically in eKYC and card creation, both, if you see, monitoring has to be very micro in nature. So we have created these district dashboards and we keep on creating. We have, I'm sure other states are also doing something similar. We have all these WhatsApp groups of different levels and we keep on creating competitions where we see, and there are micro targets. So we'll say, आज किसका 50% cross हो गया है, उसको कुछ एक, we just give him a digital certificate. That is motivation enough, I believe. First district to cross 50%, first block to cross 50%, first block to cross 70%, first block to cross 1 lakh. Any micro targets that you give them incentivizes them. Then a lot of extensive review has been done at the highest level by the minister, by the officers at different level and deputy commissioners, which has been, without which I don't think any program can succeed in any part of India. Deputy commissioner's role has to come in this kind of a program. So some challenges were identified because we don't own the portal, the TMS, the BIS, everything is owned by the NHA. So there was limited access, especially in the earlier versions of BIS and TMS. So we were raising these issues. There were certain issues which were coming up and we were working with the NHA on a regular basis. We got response from them and we were able to resolve most of these issues. Then second issue is that these agencies have limited capacity to provide cards. So whatever they promise, they are not able to always deliver. So any agency will tell you that I can give you 5 lakh cards on a daily basis. It will not be able to give you. That has been our experience, because there are a lot of issues pertaining to printing, to packaging, which then impedes the actual distribution of cards. Then it is also a huge, I would say, a Herculean task to coordinate between different agencies with which these field level workers are basically have the administrative control. So that is something that we have worked out a very beautiful system. We have a coordination committee and all this is worked out very well in our case. So outcomes, now we have 1.58 crore eKYC and as I said, in terms of population, absolute population, we are 15th in the country. So we are somewhere in between. But in terms of the eKYC done, we are 4th, I think. In terms of the actual card distributed, we are 1st in the country. Despite, as I said, being 15th in terms of the population. We have given, as I was saying, field level workers, we have just given 5.22 crore, which is not a huge amount, but which has galvanized my field level workers. And this is all done in a span of 4 months. As Rohit was saying, we were something like 6 lakh or something. Last 4 months, last 4 to 5 months, we have crossed a huge number. and at the peak we were creating more than 2.5 lakh cards on a daily basis. And as I said, the size of Assam is not very huge. So these are some of the IEC we have shown, mass IECs. A lot of work has been done. Thank you very much.
Thank you, sir, for a very crisp and informative presentation. I will quickly come to a question to you, sir. For quite some time, Assam was sustaining the whole Ayushman card drive. And I remember backward and forward discussions with you and your team. Kamalji ji is sitting here, many others. You were like, we used to have long chats over calls in the evening to see that the things are working. And even today, I'm seeing you have a chat group with the district collectors where you put everyday message that what is the performance at every district level. So the number is 1.58 story, but it doesn't tell the complete story behind how it has been achieved. So I will quick, because we at NHA are really, now Ayushman Bhava is going on and UP is kind of sustaining the drive for us. Some presentable number is coming from the UP, which we actually want rest of the states who are actually not, who have not achieved the saturation should help us achieve the numbers. Sir, I have one thing to ask from you, that how do you see the role of district collectors in the card drive, and how has the participation of district collectors been ensured? Because I have seen wherever district collectors' participation has been ensured, the numbers are really picking up. So I would like my other states to know that how this has been instrumental, sir.
What I think is, the institution of district collector, as we all know, is the fulcrum of administration largely in most of the states. But the district collector, the problem with district collector is that he has far too much work on his platter. It is a question of prioritizing. So he will do whatever the government feels is the priority. Now, from the state government side, that priority has been indicated by the highest offices. So the Honorable Chief Minister, the Minister keeps on harping on this fact that this is something which is very, very important to the state. Once it becomes the priority of the state, you will see, and that would be a pan-India. Once it is the priority of the state, the district collectors would carry it out. So, and as far as this is the larger picture, and on the micro side, as you said that we are just after district collectors, we make their lives miserable. Basically, I would say just like we have made your life miserable by daily calling, and so we don't leave it. Basically, हम लोग जान खा लेते हैं, हम लोग रोज phone करते हैं, हम रोज message करते हैं. Those who are lagging behind, we'll keep on nagging them, like we will just not leave them. And those who are doing well, we'll keep on encouraging them. We once again, some days back, we had this Ayushman Divas. We felicitated the best 3 districts, the best 3 collectors. We have given them certificates, and we keep on running after them. So district collector, without the district collector, at least in case of, I would say, at least 60-70% of Indian states, it's not going to happen. So district collector, in case of Assam, we have assigned, because PMJ has been assigned a very high priority by the state government, they are following suit.
So actually I wanted my audience to really know that how, if like card drive, if you really prioritize that, and if you really, all the, like there are different kinds of, cogs in this wheel, where you if all of them are put together, probably then only the wheel will start rotating. And if you want it to rotate at a faster pace, then probably, you have to have a very strong driver. Of course, SHE is at the driving position, but you need to elicit the support of other stakeholders, which includes the political leadership at the top, and as well as the district team, district collectors, because they are ultimately who are having control on the ground resources, on the FLWs and all. So thank you, sir. Thank you. Because of paucity of time, sir, we will be moving to the next speakers, and we'll see at the end if there are few questions we can take from the audience. Now we are going to Gujarat, and Remya ma'am is here. She is MD NHM in Gujarat and also additional CEO for implementation of the schemes. He has been seeing this scheme for last few years. Gujarat has been one of our crucial partners in terms of, it's a very compliant state in terms of, whatever we prescribe, whatever NHA prescribes, we always see a very positive response from the Gujarat. And also it kinds of innovate many things which helps us to formulate better policy for the implementation of the scheme without really going too much into that because of, again, paucity of time. I would request Remya ma'am for the presentation. Ma'am.
Thank you, Rohit. As we still have another speaker to go, I'll wrap up very quickly and try to, summarize whatever I have to say in a very small package. Have to use this laptop or?
Yes, ma'am.
Okay. Yeah. So, lot of things which have been said by my previous speakers. It also is very true. Many of the things I realized that many states have many common experiences, and as Rohit had earlier said, PMJY is implemented by the NHA, the guidelines, the policies are the same, but when it finally plays out, each state has got a unique, many unique features in the way it is implemented, the public response, the socio-economic aspects of the state also may change the way it is taken up in different states. So with regard to Gujarat, one of the big issues which we faced were, of course, the high-end packages and in the tertiary sector being, predominant, as it was earlier mentioned that per episode the cost was very high. And a lot of analysis, a lot of work we have been doing over the past couple of years trying to rationalize these things and trying to ensure that the scheme does not become too unwieldy, because in Gujarat there is a huge awareness about the scheme in the cities up to the villages. Is one of the highest priority schemes of the government of Gujarat, because earlier in Gujarat there was a Ma Yojana which was started by Honorable Prime Minister when he was the Chief Minister, and now that has been co-branded and integrated with PMJY. So we actually implement PMJY Ma, and within that we have got a group of beneficiaries who are totally funded by the state government. So up to 6 lakh senior citizens, up to 4 lakh normal citizens are also included under this whole umbrella of PMJY Ma in Gujarat. So it makes the whole scheme, managing the scheme a little bit more complicated, and it has very different nuances from just picking up what is instructed from NHA and implementing it. So considering all these issues which we faced, so we started focusing on high-end packages, and one of the biggest achievements which over the last few months which we have had is we have developed a system to control the overuse of the total knee replacement packages. We studied the pattern and we realized that the private hospitals, referrals from government hospitals to private hospitals, etc. was very large in number. So we developed a software, and we reserved below 55 years of age TKR with the government, and made various checks and balances, including QR code based doctor certificate, monitoring the number of procedures, TKRs which can happen within one operation theatre on a single day. And doing all that, trying to find the points where the shoe pinched, and just cutting down on that, we really were able to reduce the numbers by almost half. And the point being that no deserving patient should be denied At the same time, no malpractice or nexus with private hospitals, that should not happen. That was our intention. Even for packages like hysterectomy, which were really, much above the normal numbers. So we studied those patterns and we reserved those also for the government sector. Another point where we try to use positive reinforcement and positive engagement with the public is over and above IEC or communication strategies. We have a 24/7 call center where we make almost 3,000 outgoing calls to the patients who have patients' relatives who have been given the pre-auth. And so we are able to have a dialogue with them, the issues they are facing, whether the hospitals are charging them. For example, in TKR, another thing which we did is that we tried to enforce that no hospital is only exclusively doing TKR. They should be at least 30% of their procedures should be this casual, the different other orthopedic packages. So this is so that a hospital cannot just be into money making using total knee replacement. So all that has brought about very good results. We are able to know. We are able to gain the confidence of the patient and the public over the last couple of months. We realize that people are gaining confidence that yes, there is somebody who is listening, there's somebody who is out there who is asking us, are you all right, is everything going well? And we are getting and now we are getting almost 1,000 inbound calls also, over and about the 3,000 outbound calls which we are doing. So this two-way communication system and this direct engagement with the patients have made our hospitals also more alert, because they realize that they cannot just cheat the patient or trick the patient or misinform the patient about the various aspects of the scheme. Another thing which we developed is an incentive package application for incentive distribution. There was a lot of lack of uniformity in the way various hospitals were distributing the money, the 25% which is supposed to go to the teams, starting from the doctors to the staff of the hospital. So we made a uniform policy for that and an online tracking system up to the level of the DBT to the account of the the ward boy or the sweeper, so that there is no other mismanagement in the hospital level. And that has also definitely motivated the staff, and our SHA team has been strengthened, our state anti-fraud team has been strengthened, and this is something which we are working very hard on to ensure that we have a completely expanded call center, and we are also recruiting data analysts, etc., and trying to sort of dovetail it with ABDM as well, so that we can perform better on these lines. I'll not go much into the details, but in this context about two things which Tamil Nadu and Kerala also mentioned, that we have taken up something called a hospital patient care improvement mission in Gujarat, where this whole concept of attracting people to the public sector, where many of our doctors are very experienced, very skilled, but there are small things like the look of the hospital, certain equipments are not there, certain tests are not performed in our labs, turnaround time is too much, there's no patient guide, the soft skills, the behavior of our counter staff, the privacy in the rooms for let us say the ECG rooms, or the cleanliness, and all these kind of things which overall the physical evidence and the actual core aspects of a hospital which attract people to come from let us say private to the government hospital. So using the PMJY funds, the Gujarat CSR Authority funds, plus all other convergence, we have identified the gaps in almost 94 hospitals, tertiary hospitals in Gujarat, and we have identified funding also for how we are going to fill these gaps. So in this also the PMJY, the funds which are flowing to the Rogi Kalyan Samitis of the hospitals will be very useful, and we have have already started utilizing it. So Gujarat is also following this same model which sir from Tamil Nadu and Kerala said, that we improve our hospitals to such a level that people are themselves attracted to come to our hospitals instead of going to the private sector. We have also engaged beneficiary facilitation agencies, and we are trying to encourage the government hospitals to ensure that every single eligible walk-in, PMJY eligible walk-in should come under PMJY, because many times government hospital heads have this attitude that anyway the treatment is free, why would we do the extra paperwork for PMJY, and so we are trying to motivate them, convince them, train the staff down the line, and hopefully now we have had a 5% increase in the claims in the government's public sector. Hopefully it will improve over time. We are pushing very hard on that. So this is just a short after doing all this, every day we find new things, new gaps, new positive stories. We have many stories where actually we have spoken to the patient, got the money returned to them from private hospitals who have taken money wrongly and actually misguided the patients. So hundreds of such cases are there where we are building confidence among the public, and we are trying to keep the private hospitals also as a positive stakeholder, increase their confidence in the government system, and we are trying to reduce the burden due to manipulation of high-end packages like cardiovascular surgeries, oncology and TKR. From my side, this is all. Thank you so much.
Thank you, ma'am. This is very important, this kind of selective intervention, that like the one which was done by the Gujarat for the TKR, that which numbers are inflating, and you are able to, the SHs need to keep tab over that which are the sectors, identify where there is undue kind of increase in numbers. So numbers are good, but if numbers are influenced by certain factors which is probably not good, then those have to be controlled. I would request all the states to really please reach out to Gujarat for both these apps, TKR app and incentive distribution app, if you have not developed for yourself. Why TKR app? Why TKR app? I just need to ask, I'm requesting one input from Remya ma'am, that what are the lessons which you probably would like to share with others about the replication of the TKR app for other procedures? So one, you have identified TKR and you have made intervention, and there are a scope for replicating the same model for other packages as well. So ma'am, you would like to say something about that?
Yeah, TKR was, of course, because it is because we were regularly analyzing the numbers, and it was much above the acceptable average, which is for a state like Gujarat. So that is why we decided to go drill down deep into it. Then we analyzed hospital-wise. Are there any particular hospitals who are doing too many? Are there any particular doctors doing? And we also analyzed. We also have developed something called a smart referral system, the benefit of the patients, so that in the golden hour people are correctly referred by the 108 ambulances to the right hospital where all the facilities, doctor, etc. is there. But using that smart referral, we also got the data that there were so many government hospitals who, even though they had all the setup and the doctors, they were referring to private hospitals for TKR. And so using this smart referral app and this TKR app, we were able to control this. So in a similar way, we are analyzing the data from all the packages, and we will try to our best to plug positively these kind of loopholes.
Thank you, ma'am. Again, because of paucity, we need to rush to another speaker. We have last speaker of the day, Rajesh sir. He is Secretary Health in Uttarakhand. Uttarakhand has been one of the best performing state in the country in all aspects of implementation, and the only state which is adhering to the TAT of less than 15 days. So of course that is because of it's more about there are limitations in terms of funds and everything, but it is more about making it a policy. It is more about making it a principle and following it. There are other states which are falling between 15 to 20 days, but our benchmark is 15. We have set this benchmark of 15. So this is one thing, another concern area for all of us, and also very important best practice. I understand this is really like we are crossing 7:40 in the evening. I would request all of you to please pay attention for this presentation, because this is very important for the scheme to sustain and for the scheme to attract, participation from our service providers. I will not get into much of the, introduction, sir. I request you for the presentation.
Thanks a lot. First of all, big round of applause for all of you. I've never seen such a sincere crowd in my life. You people exceed all expectations. I was thinking that being the last speaker, I'll have to just address 5 or 10 people. But people are just trickling in, and that makes it very scary, in fact. So, being the last person to speak, call it the curse of the night watchman. So I'll be very quick and say Uttarakhand takes 7 days to adjudicate claims. I'll take less than 7 minutes to complete this presentation. Only three concepts that you need to remember. I'll rephrase it in the end. Only 3 concepts. My presentation is on anti-fraud measures and claim adjudication. So there is one anti-fraud measure that we adopt very efficiently. It's called DQAS, a daily quick audit system, right? DQAS, and 2 quick claim adjudication measures. It's called, one is quick TOT, an unwritten code of quick turnaround time at each level. And the second thing is quick pre-authorization. That's all. Presentation over, but since my people, they've taken a lot of pain to do the presentation, they'll roast me alive if I don't make the full presentation, so I'll just rush through it. So just 3 concepts. Next. There's no one?
Okay, I will play for you.
I just wanted to save time going there and coming back so that your time is saved.
They are doing it, sir. They are doing it.
So the problem statement. So what normally happens is there is a delay in pre-authorization at the level of the ISA. The average time is, I am made to believe, around 6 hours for private hospitals and 12 hours for government hospitals. In Uttarakhand, we do it in 30 to 45 minutes. The average is 59 minutes, but 30 to 45 minutes. And the direct consequence of that is delayed payments to the empaneled service providers, which mean the hospitals. And somewhere in this system, the entire system is based on the efficiency of the implementation and support agency, the ISA. But there is no system of checks and balances to see whether how the ISA is actually functioning. So that is something which we have introduced, and that is called the DQAS system, which I elucidated initially. Obviously, fear of fraud and abuse and satisfaction of the consumers et al. Next. So what is this system of DQAS and how does it function? Who does it? It is done at the level of the state health authority, as simple as that, SHA. And the DQAS system is headed by the CEO himself, and if there is a chairman, it is headed by the chairman. So it is a system of auditing the claims processed by ISA, that's all. ISA does the processing of the claims. The DQAS system, it's an in-house system which monitors and assesses whether the claims which are processed by ISA are done in a proper manner or not. And how is it done? It is done through a system of triggers. How many triggers? 10 to 15 triggers. And what are those triggers? I'll just give you 3-4 examples. Whether the treatment or treatment or surgery has been done before pre-authorization, whether the pre-authorization has been initiated after the day of discharge, is there a history showing a lot of stay more than the days which are mandated, and are there some unnecessary procedures being added apart from the procedures which are normally necessary? So these are 4-5 triggers. There are like 10-15 triggers. I'll explain the system in a little bit greater detail in the next slide. So, no, just back. So what does this do? This actually places a system of checks and balances on the implementation support agency and prevents abuse, misuse of fraud. But at the same time, opportunities are given to the hospital, say supposing some genuine claim is missed inadvertently by SHA or during the process of DQAS, there is a separate system, a separate website which is run by SHA for people to say that no, these claims have been genuinely missed by SHA. We are not saying we are the know-all of existence and that we know everything. We have a separate, this is a system which is separate from the TMS system which Government of India has had. A separate website, and in that website, say supposing any claim gets genuinely missed, the hospital can again reclaim and the claims are again re-looked into. So it's not only a system of check and balance on the ISA but also on SHA as well. Next. So what we do is once the claims are processed by ISA, we bring them onto a separate Excel sheet, and then that is dump data. Dump data is brought onto a separate Excel sheet. The 10 to 15 filters are applied using data analytics, and then you cull out, you observe for some abnormal activity on part of the hospital. That's all. So and these parameters which I had mentioned to you just a few slides back. So based on those parameters, the abnormal activity gets automatically culled out. This entire process just takes 2 to 3 hours. That's all. Only once this is done, the claims are sent to the finance division of the SHA. Next. So, what are the challenges though? One challenge is that because it has to be done on a daily basis. So you need manpower, a dedicated manpower who's trained and also dedicated to look at the flaws if there are any, and with a trained eye, that is. And there is also, but sometimes what happens is you also tend to, even you do a lot of check, recheck, sometimes you do tend to miss it. For that, there is a DQAS on a DQAS. What we do is, for those claims which get missed, we employ a system of DQAS weekly and monthly also. So it is a total comprehensive system, and it ensures the accountability of all these 3 major players. One is the implementation support agency, the ISA, the hospital, as well as the SHA, ensuring all-round transparency. Next. So outcomes need not mention. That the most important thing that I would like to highlight here is that the corrective action is taken at the stage of processing of the claim itself, not at the stage after payment. Normally what we do is we do post-mortem. पेमेंट होने के बाद फिर हम लोग कॉल करते हैं और पूछते हैं कि अगर गलत क्लेम हो गया दोबारा सबमिट करो, बट इसमें क्लेम जब प्रोसेस होता है उसी समय हम लोग जो है बिल्कुल सटीक तरीके से वो गलती जो है, जो अगर कोई गलत क्लेम है तो उसको कल आउट हम लोग कर लेते हैं. Almost zero level of fraud and misuse, and payment is done within a period of 7 to 10 days. We have also introduced 2 forms, one for the hospital and one for the patient. So when the hospital submits the claim, the hospital says, certifies that we have not taken any money from the patient. And the patient also does the same. The patient also has to submit the form. Only when these both forms come to SHA during claim processing are the claims processed. Otherwise, the claims are not processed. Next, last. So, I think it is a sign for me to finish. This is the last slide. So out of 8,07,000 claims from 2018 onwards, we've rejected around 31,000 claims. The rejection percentage is 4%. National average is 2%. It is more than the national average, but at the same time, it has resulted in saving of around 137 crores to the tune of 137 crores to the state exchequer. And that is a huge amount for a state like a small state like Uttarakhand. And we have de-empaneled 53 hospitals also. But the icing on the cake is that in spite of so many hospitals being de-empaneled, the participation of the private hospitals has grown by leaps and bounds. Thank you.
Thank you, sir. I just want to ask you a very simple question, sir. That how all of this activity, your estate has been very upfront about anti-fraud actions and have been paying claims on time. How have you been able to manage the expectation of private providers, and has their participation increased or not?
In 2018, the number of private hospitals was around 112, and as on date it is 148. So it just goes to show that if there is a robust process of check and balance, if the system is honest, accountable, transparent, and has all the checks and balances in place, and if the right people are rewarded and people who indulge in fraudulent activities are not rewarded and are punished, that one time, I think people do understand, the hospitals do understand that it is a system of, it's a purely meritocracy-based system and a merit-based system, and I think ultimately this is a pure example of how a proper merit-based system can succeed.
A concluding remark from our chair, Gagandeep sir, about the different best practices presented by the state, sir.
Thank you. My concluding remarks will be very short. It was a wonderful presentation by everybody over here, I must say. And every speaker, right from Kerala to Gujarat to Assam to Uttarakhand, has indicated that each one of us has to learn best practices. Actually, I will say perhaps that though it's the last, but for all of us who have listened to it carefully, it has been the most fruitful session, because there are many takeaways for each of us to take from this session. I can very well say, in fact, I have made a mental note about how I will involve all the administration, district administration, and reward the people for e-cards like done in Assam. And how all the Kerala best practices have to be undertaken, and how I am also alerted to my mind that I should also check about all the total knee replacements being taken up in all the hospitals. We should not have been swindled by any particular institution in this regard. And the timing of Uttarakhand has been amazing. Like within 1 or 2 hours, they are able to do the entire pre-authorization check, so that later on the rejections are not there. So that there are all takeaways, and in fact, I will like to make a request on behalf of everybody over here to Mr. Rohit. You have mentioned that all the best practices books are there with all of us, but I think we have not yet got the books. At least I have not got the book.
We'll share with you, sir.
Pardon?
It's an e-book, sir. We'll share the link.
It's an e-book.
Yes.
So we will like to go through all these best practices. And I must like to finally say that the moderator, that the coordinator of this session has been very lively, that is you, and you have handled this session very well. Thank you so much.
Thank you, sir. Thank you very much, sir. Just want to say one thing. We are concluding the session that PMJY has been a catalyst in a big way to march the country, to promote the march of the country on the USC. Today we have 12 states who are implementing USC. It has brought the true essence of cooperative and competitive federalism. In like if one scheme, if we talk about, PMJY, where every states are competing with each other to see that how they are going to give better services to their people, and this is truly captured. This sense of competitive and cooperative federalism is truly captured in the best practice session which we had today, and I'm sure next year we will have many more, maybe in a much more diverse way. We will have, best practices which others can emulate. Thank you very much to all the speakers, chair sir, and everyone, especially to the audience for sorry, we will not have any questions, and I'm sure you also do not want that. So we will just have a last formal activity. We'll present our memento to the chair and the participants. Thank you.
Thank you, everybody, and thank you to our lovely audience for staying through the entire session. Thank you to our panelists and moderators for such an insightful session, and we hope to continue our learnings even beyond Manthan. As said, the book will be available online, and we will share the link with you. We would like to conclude the session with the presentation of mementos to all our panelists, starting with our chairperson. I request our moderator, Rohit sir, to present the memento to Mr. Gagandeep Bedi. I would like to request Rohit sir to now present it to the panelists, starting with Dr. Rathan Kelkar, Dr. Siddharth Singh, Ms. Remya Mohan, and Dr. R. Rajesh Kumar. We'd also like to call upon SHA CEO Jammu Kashmir, Mr. Sanjeev Gadkar, to receive a special award. Thank you, everybody.
We have our award session in the hall number 5. Please join us in hall number 5.
Yeah.
Because they had finished it early, so we are taking hall number 5. There is no preaching over there. You can just